In this lecture, we will discuss obesity. And obesity is defined as a complex health problem that involves excessive amount of body fat. When we say complex health problem, is because obesity consequences and it increases the risk of cardiac diseases, diabetes, hypertension, arthritis, etc. Um, when we assess obesity, we commonly use body mass index. And the cutoff body mass index for obesity is 30 kilogram per meter square. So this is the number when we say to someone that he or she is obese. There is, however, recently significant debate among clinicians whether the use of the body mass index is really the best way to assess obesity or not. Why? Because body mass index can be misleading. For example, if you have an athlete person who has excessive muscle mass. This athletic person, when you calculate the body mass index, he or she may appear to be obese based on the body mass index. But the body mass index is high because of the muscle mass, not because of the accumulation of fat. Also, some adults don't reach their full growth potential. Elderly. Also, the body mass index can be misleading in elderly. And also, some ethnic groups may have a misleading body mass index. So now there is a increasing trend that body mass index itself, like by itself, is not enough to assess obesity, because also what matters to obesity is the distribution of fat. Is the fat outside fat, like fat just under the skin, or this is fat inside the body surrounding the organs? So distribution of fat rather than body mass index plays an important role in increasing the risk of cardiac complications. And that's why now they are using body mass index along with waist circumference. So here is the cutoff number for the waist circumference, which is 102 centimeters in males and 35 inches in um, in females.
Obesity can also be drug induced, and here we listed some medications that may cause obesity. So steroids such as prednisone and dexamethasone. Also sex hormones, something like androgen or like testosterone, or female sex hormones like estrogen. Insulin preparations and insulin secretagogue. So this includes nucleotides and sulfonylurea. Antidepressant medication, something like tricyclic antidepressants, MAO inhibitors, and mirtazapine. And as you know, it is unclear whether weight gain is a side effect of antidepressants or it's just a reflection of the improvement in appetite in patients with depression. Also, typical and atypical antipsychotics can cause weight gain. Mood stabilizers like lithium and valproic acid, carbamazepine, and the glitazones like pioglitazone and rosiglitazone. As we mentioned on a previous slide, there is lots of criticism to the use of body mass index in assessing obesity. And we give an example for an athlete person who has large mass muscles. If we do the calculations, this person may appear to be obese. However, this person is typically healthy. And that's why there is a new Canadian system now that tries to assess obesity, which is the Edmonton Obesity Staging System. So this system gives patients a score from 0 to 4, and it chooses criteria such as the risk of mortality, in overweight individuals based on the obesity related comorbidities. So, if the patient is severely obese and the patient has many complications of obesity, they also consider the risk of mortality. Also, they look at the functional status, psychological status, and the effect of obesity on the patient's quality of life. So, for example, just I don't think you have to memorize the different stages, but patients with stage 0, they have no obesity or no signs of obesity related risk factors. They have no physical symptoms, like they're not obese, they don't look big. They have no psychological symptoms, and they have no functional limitations. So the patient doesn't complain, for example, of knee pain, for example, because of the obesity. So that's a stage 0. On the other side of the scale, stage 4, these are patients who have severe and potentially end stage disability coming from obesity related comorbidity. They may have severely disabling psychological symptoms, and they may have severe functional limitations or severe impairment in the quality of life.
So this is the first question in obesity section, and the answer for this question is B, 85.3 kilogram, and this is the equation that we use to calculate the body mass index, and it's good to know this equation. Next question. Next question is about the ideal body weight, and the answer for this question is C, and the equations that are used will be on the next slide, so you may write them down. So these are the equations for the calculation of the ideal body weight. Now, there is what we call the obesity management framework, which was suggested by Vallis and others. Um, so it depends on using 5 A's. First one is ask the patient for a permission to discuss the issue, and make sure that you don't become judgmental. So you don't talk about like eating habits. Like, try to make sure that you are neutral, and keep in mind the patient may not be ready to discuss his weight with you. So that's fine. That's why you are asked for permission. Number two is to assess. If the patient is okay to talk, you do assessment. You calculate the body mass index, and you calculate risk factors, and you measure the weight circumference. Then you advise. You educate the patient on the risks of obesity and the benefits of weight loss. Then you agree on a plan. So you develop a plan, and you establish realistic goals of weight loss with the patient, and you both agree on this plan. And then you assist by offering support during the weight loss program. This is what they call it, the 5 A's um, framework for obesity management. So now, what is the realistic target? And the answer for this question is B. Reducing the body mass index by 5 to 10% is a realistic target for most obese individuals. Reducing body weight by 5 to 10% can significantly reduce the risk of cardiovascular comorbidities in obese patients. Another realistic goal, if Another realistic goal, so one realistic goal is to reduce the body mass index by 5 to 10%, or reducing the body weight by 5 to 10%. Another realistic goal is to reduce the body weight by half to 1 kilogram per week over 6 months. 6 months, you are looking for about 24 weeks. If the patient uses zero point 0.5 to 1 kilogram per week, you are looking for a loss of about 12 to 24 kilogram per week, and this is a realistic target. So how many calories do we need to cut to lose 1 pound of fat? And the answer for this question is C. So we need to lose about 3,500 calories in order to lose 1 pound of fat, and this can be reasonably achieved by um, cutting the caloric intake by 500 calories per day. 500 calories per day over 7 days, the patient can lose 1 pound of fat over 1 week. Now, some stuff that we need to keep in mind when we talk about this is to maintain the muscle mass. So very important that um, the patient should maintain good protein intake. It is important for the patient to drink lots of fluid because this helps to maintain the muscle mass. It is important for the patient to also take a little amount of carbohydrate. This also helps to maintain the muscle mass. Now, another thing that the patient has to keep in mind is what we call the roller coaster effect. So usually in weight management, there are two phases. In the first phase, the patient restricts the caloric intake to lose weight. And during this phase, the patient is so motivated, he's losing weight, everything is perfect, till we reach a plateau phase. At the plateau phase, the patient stops losing weight. And when the patient feels that, okay, well, he's not losing weight anymore, at this point, the patient will slowly start to increase his caloric intake, and that's what will result in weight gain. So this is what we call the roller coaster effect. Next question is about what we will do after losing weight. And the answer for this question is A. We should not increase the caloric intake. We have to maintain the caloric intake at the same level that we use to lose weight. And that's the problem. That's the roller coaster effect. When the patient restricts his caloric intake and loses weight, the patient is very motivated to continue his diet. But once the patient reaches the plateau phase and he doesn't feel there's any weight loss anymore, most patients will tend to slowly start to increase their caloric intake, and they go back to the pre-diet level, and that's when they regain the weight that they lost. Uh, Things that the patient has to do to keep the weight loss is exercise. And with exercise, we talk about 10,000 steps per day, which is about 30 to 45 minutes of walking every day, 3 to 5 times per week. It's very important to make sure that the change in the lifestyle is kind of permanent change. The diet habits, the meal size, stuff like that has to be permanently changed. And if the patient is taking any medications for weight management, the patient will need to keep taking this medication to maintain the weight loss. So next question is about designing a nutritional plan for obese patients. Well, I totally understand that this is not necessarily something that the pharmacist will do, and you may need to refer the patient to the dietitian. But when we are designing a nutritional plan, all of the following should be discussed, except, and the answer for this question is D. It is important for the patient to eat 3 meals and to have 3 snacks between meals. Skipping meals, especially breakfast, or fasting for prolonged time, reduce metabolic rate and may lead to weight gain. Let's now look at the other choices we have here. So for choice A, it is important for the patient to have daily protein intake of a minimum of 1 gram per kilogram of the body weight per day. to maintain the muscle mass. So A is correct. Similarly, patients should consume at least 100 grams of carbohydrate per day um, to save the muscle mass by preventing protein breakdown. What happens is when the patient does not take enough carbohydrate, which is the main source of energy, the body will start to convert protein from the muscles into energy. So the patient will start to lose uh, his muscle mass. Complex carbohydrates, like the ones in beans, in whole grains, stuff like that, are the preferred carbohydrates because they are digested slowly and they don't cause sharp increase in the blood glucose level, which means that they have low glycemic index. So what happens is when the patient consumes medications with high glycemic index, the ones that causes sharp increase in the blood glucose level, the food with high glycemic index that causes sharp increase in the blood glucose level, it causes also sharp increase in the insulin level, and this puts the body in fat storing mode. So the body will be storing fat. So it is important for the patient to use carbohydrates in a complex format like the ones in beans and whole grains. As we mentioned before, patients should not skip breakfast. The last one, E, this is also an important one. So limiting the fat intake to 30% of the total daily calories is important, not only for weight loss, but also to prevent cardiovascular comorbidities. And in fact, using low-fat diet was found to be comparable to using low-carbohydrate diet. There are a few more points here to keep in mind. There are two types of diet that are commonly recommended. The first one is low carbohydrate, low fat diet, and the other one is the Mediterranean diet. Another important non-drug measure for weight loss that I'm sure you are all familiar with is exercise and increasing physical activity. An effective weight management plan must include both measures, the increased physical activity and dieting. Dieting alone may help the patient to lose weight, but it also can lead to loss of muscle mass and bone mineral density, while physical activities reduce the risk of these side effects of dieting. On the other side, also, physical activities without caloric restrictions will not be enough for weight loss. It is very important to discuss with the patient adherence to the dieting plan. So, all types of diet and all types of diet plans that restrict caloric intake and fat intake appear to be equally effective. So it is important for the patient to choose a diet plan that the patient will likely adhere to. The last one is patient may use meal replacement in case the patient cannot have his meal. Meal replacement can be used to replace a meal if the patient is not able to eat a meal or take a snack or something like that. Meal replacement can be used. Okay, so now we'll start looking at the effect of obesity in pregnancy and lactation. So it's actually, this effect is going through different phases. So preconception, um, the female may have early menstruation, may have amenorrhea, may have irregular menstruation, or polycystic ovary and infertility. In pregnancy, obesity will increase the risk of gestational diabetes, hypertension, and C-section with all the complications of the C-sections. To the embryo, when a pregnant lady is obese, the embryo is at increased risk of macrosomia, which is to have a large baby, congenital malformations such as neural tube defect and oral cleft, and prenatal death. Anemia and obesity in infant are common among children who are born to obese mothers. They commonly have anemia and obesity when they are born. For breastfeeding, obese mothers may have several problems during breastfeeding. So obese pregnant females tend to have more C-section. When the female has C-section, this delays the initiation of breastfeeding. Delaying the initiation of breastfeeding by more than 48 hours leads to reduction in the amount of milk, which in turn will lead to a shorter duration of breastfeeding. So if instead of being able to breastfeed the baby for 6 months or for a year, it will be a shorter period of time. So how do we manage um, obesity in pregnancy? So very important in pregnant and breastfeeding mothers who are obese to become physically active and to eat healthy. Obese pregnant women should be also advised to not try losing weight during pregnancy. The pregnant lady who is obese should not try to lose weight during pregnancy. She should do this before conception. Orlistat. Orlistat is associated with impaired absorption of fat soluble vitamins, so it should be avoided during pregnancy and during breastfeeding. Bupropion. Bupropion has limited data. If the pregnant female is taking bupropion during pregnancy and the benefits appear to overweigh the risk, the treatment should continue. In breastfeeding, even though bupropion secretion in the breast milk is minimal, there are some reports suggest that seizures can happen in the children when the breastfeeding mother, takes bupropion. Now we'll start looking at medications used specifically for weight management. And the first one we have is liraglutide. And liraglutide is an anti-diabetic drug that during clinical trials was found to reduce body weight. And that's why now we have a brand of liraglutide, the Saxenda brand, that is indicated for weight management. Saxenda is indicated as adjunctive therapy for chronic weight management in patients who also use reduced calorie diet and increased physical activity. So it's adjunctive to reduced calorie diet and increased physical activity. It gives the patient about 8 kilograms of weight loss, and this is usually maintained for 2 years. The candidates for using Saxenda include those with initial body mass index of 30 or more. So basically, those are the individuals who are classically obese. They meet the definition of being obese, body mass index of 30 or more, regardless whether they have other cardiovascular risk factors or no. So they don't have to be diabetic to take Saxenda. As long as their body mass index is 30 or more and they meet the definition of being obese, they can take Saxenda for weight loss in conjunction with reduced calorie diet and increased physical activity. Saxenda also can be used in patients who are not yet obese. These are the overweight with body mass index of 27 or higher in the presence of at least one weight-related comorbidity. For example, if the patient has body mass index of 27 and hypertension, or body mass index of 27 plus type 2 diabetes, or 27 body mass index plus dyslipidemia. And these patients who will take Saxenda have failed a previous weight management intervention. The second drug, which is the famous drug for obesity, which is orlistat. Orlistat inhibits the pancreatic lipase enzyme, which is the enzyme responsible for the digestion of fat. And by inhibiting the digestion of fat, orlistat also inhibits the absorption of fat from the GIT. In terms of indications, it's used for obese patients who has a body mass index of 30 or more. And again, these are patients who are technically considered obese. Sometimes we use them in patients who are classified as overweight, who has a body mass index of 27 or higher. And it's used in the overweight when they have two of the cardiovascular risk factors, as I mentioned on a previous slide, like hypertension, like diabetes, like hyperlipidemia. In weight management, orlistat is only used as adjunctive therapy to diet and exercise. It also can be added to sulfonylurea, metformin, or insulin to improve the glycemic control in patients with type 2 diabetes. And orlistat also reduces the risk of type 2 diabetes in obese patients who have impaired glucose tolerance. So it can reduce the development of type 2 diabetes or the progression of type 2 diabetes from impaired glucose tolerance. It prevents the impaired glucose tolerance from becoming an actual type 2 diabetes. In terms of administration, orlistat should be taken as 120 milligram during or up to 1 hour after the 3 main meals. The patient should limit the fat intake to not more than 30% of the total daily calorie, which we mentioned that before in the nutritional plan, and the fat amount should be split over the 3 meals. If the meal is missed or it contains no fat, then orlistat capsule may be missed. You don't need to take the orlistat capsule because orlistat works by inhibiting the fat digestion. If there is no fat, there is no point of taking orlistat. Just to one quick point here, the same way of administration will be used if we're using orlistat to improve diabetes. It's exactly the same way of administration. There's only one way of taking orlistat with fat-containing meals. There is no special way of taking orlistat when it's used for diabetes. In terms of contraindication, orlistat is contraindicated in patients with chronic malabsorption syndrome, hypersensitivity, and those who have cholestasis. Some of the common adverse reaction, very basic to understand. Why? Because it inhibits the fat digestion, so the bowel is full of fat. This leads to oily spotting um, and oily stool, fecal urgency, oily evacuation, fecal incontinence, abdominal pain and discomfort. It also causes upper respiratory tract infection, back pain, headache, fatigue, and menstrual irregularity. We'll start look at some drug interactions for orlistat. So orlistat increase the effect of warfarin and increase the INR by impairing the absorption of vitamin K, which is a fat-soluble vitamin. So when you impair the absorption of vitamin K, you increase the effect of warfarin. Orlistat impair the absorption of anticonvulsant drug and increase the risk of having seizures. Orlistat also reduces the absorption of amiodarone and cyclosporin. Orlistat interacts with other drugs as well, such as oral contraceptive, levothyroxine, and anti-diabetic drugs. So the patient who's taking orlistat should be monitored for or educated on all of the following except, and the answer for this question is F. The patient should be monitored and educated on all of what's listed here. So orlistat may cause hypothyroidism by interfering with the absorption of iodine. Um, Cases of rectal bleed, severe hepatocellular necrosis, and acute liver failure, and cases of pancreatitis were all reported in patients taking orlistat. So the patient should be educated to report symptoms of liver toxicity, such as yellow coloration of the eyes or the skin or the stool, or loss of appetite or abdominal pain. Orlistat also commonly causes diarrhea that can be severe. The diarrhea can actually interfere with the absorption of oral contraceptive, and a backup method should be used. And we mentioned that on the previous slide that orlistat may interfere with the effect of birth control. Orlistat interferes with the digestion of fat, and thus it also reduces the absorption of oil-soluble vitamins. And that's why oil-soluble vitamins should be recommended in patients who are taking orlistat.
So now we'll talk about the new drug that's approved in Canada for obesity, and the drug name is Contrave. And Contrave is a combination of naltrexone plus bupropion. These two ingredients, naltrexone plus bupropion, they work by affecting two separate areas in the brain that regulate food intake. So they affect the first area is the hypothalamus, which contains the appetite regulatory centers, and that's how they regulate the appetite. And they also affect another area in the brain that's called mesolimbic dopamine pathway. This is the these are the centers responsible for rewarding system. This is um, when someone feels good after eating. So by regulating the mesolimbic dopamine pathway, these two medications or this combination will control the pleasure feeling associated with the food intake. Contrave, in terms of indications, it's medication used for obesity. It's indicated in obese patients whose body mass index is 30 or higher, so those who really meet the definition of being obese, or those who are overweight with body mass index more than or equals or more than 27, with at least one weight related comorbidity like, yeah, the patient is not obese, the patient is overweight, body mass index 27 or higher, but on the top of that, the patient has hypertension or type 2 diabetes or dyslipidemia. So, body mass index 27 or higher with at least one of the obesity related comorbidities. In terms of contraindications, Contrave is contraindicated in patients with seizure or those who have a condition that predispose them to seizures, such as alcohol withdrawal or those with bulimia. So basically, these contraindications, the seizure contraindication is because of the bupropion. So you can always go back to the bupropion monograph under the CNS for more information about this. So the first contraindication is patients with seizure or conditions that can precipitate them to have seizures. Contrave is also contraindicated in patients with uncontrolled hypertension. We can use it if the height of the blood pressure is controlled, but if it's uncontrolled, it's contraindicated. It's also contraindicated in patients who use opioid chronically or in patients who are using opioid agonist. Why? Makes sense because naltrexone, which is an opioid antagonist, can precipitate withdrawal symptoms in patients who have been taking opioids for a long time. So before we start Contrave, it's very important to make sure that the patient is opioid free for 7 to 10 days before starting. So the patient must be opioid free for 7 to 10 days before starting Contrave. Otherwise, the patient may experience withdrawal symptoms. Now we'll talk about the dose and administration. With this medication, we start low and increase the dose slowly. So we give one tablet, which is 8 milligram plus 90 milligram daily for 1 week, then BID for 1 week, then two in the morning and one in the evening for 1 week, and then two BID. So the total dose becomes to 32 milligram plus 360 milligram, 32 milligram naltrexone plus 360 milligram of bupropion. The patient should take it with food, but not fatty meals. And the need to avoid fatty meal is not only because it can cause weight gain, but because it significantly increases the blood level of the two ingredients and increase the adverse reactions. So here, when we tell the patient don't have fatty food, we are not only concerned about weight, but also concerned about adverse reactions. Another important point to keep in mind that if the patient misses a dose, the patient should skip the dose. Taking two doses too close together can increase the risk of seizures, so simply just skip it. Certain patients may need lower dose. Patients taking ticlopidine or clopidogrel and those with mild to moderate hepatic impairment should not take more than one tablet BID. So that's one of the important dose limitation. Ticlopidine or clopidogrel and patients with mild to moderate hepatic impairment. In terms of adverse reactions, nausea is the most common adverse reaction. It also causes constipation, headache, vomiting, dizziness, insomnia, and dry mouth. In terms of monitoring, we actually do have some important monitoring points that we need to keep in mind. Contrave can increase the blood pressure. We just said that. It's contraindicated in patients with uncontrolled hypertension. And when it increases the blood pressure, it can actually cause tachycardia. The risk of the increase in the blood pressure and tachycardia is higher during the first 3 months. So it's important to monitor the blood pressure at the beginning of the treatment and then routinely during the treatment. It's also important to monitor the body weight. Someone will come and say, well, this makes sense. If the patient takes the drug for weight, we need to monitor the body weight. But just a second, there is an important point here. The body weight should be evaluated after 12 weeks of reaching the maintenance dose. Reaching the maintenance dose takes about 3 weeks, and then we wait for 12 weeks after that. So it takes a total of about 15 weeks. If the patient, after 12 weeks of reaching the maximum dose, has not lost at least 5% of the baseline body weight before starting therapy, then discontinue Contrave. Why? Because this means that the patient will achieve insignificant or meaningless weight loss. So let's say a patient who is 100 kilogram is starting Contrave. We give the dose, we escalate the dose to the usual maintenance dose. It takes 3 weeks to reach the maintenance dose. Once we reach the maintenance dose, we wait for 12 weeks and then we measure the body weight. If the body weight is 95 or 96, so the patient didn't lose, like the patient didn't lose 5 milligram, 96 kilogram, 97 kilogram. If the patient didn't lose at least 5 kilogram, then stop the Contrave. Our target is to lose at least 5% of the baseline body weight by week 12 after reaching the maximum dose or the usual dose. If we don't achieve this target, discontinue therapy because this means that the patient will achieve a meaningless weight loss. Couple of drug interactions. We avoid a combination. We avoid combining Contrave with ritonavir, lopinavir, and efavirenz because these are strong to the 6 inhibitors that can increase the blood level of the medication and it can increase the adverse reactions.
We mentioned before that very important for the patient to have lifestyle changes. Lifestyle changes include diet and physical activity. If you add a drug to this, you will get the most effective um, regimen. But as we mentioned before, the drug therapy should be continued for as long as they are effective. None of the drug therapies that are used to reduce body weight were found to reduce mortality. None of them. Obesity, Saxenda, whatever, they don't reduce mortality due to the obesity. Topiramate is used off-label for weight loss. So the last few notes here are about the surgical options for weight loss, which what we call the bariatric surgery. So who are the candidates for bariatric surgery? Obese patients who have a body mass index of 40 or more without anything else. Just having body mass index of 40 or more, that's enough to be a candidate for bariatric surgery. Some patients will be candidates for bariatric surgery at a lower body mass index of 35. That's when they have other comorbidities such as type 2 diabetes, hypertension, reflux, coronary artery disease, or when they have diagnosed sleep apnea. There are 5 common surgical procedures that are used for obesity. The first one is gastric bypass surgery. The gastric bypass surgery is when they bypass part of the to hold the stomach. It has some complications. For example, because you bypass the stomach, you increase the pH of the gastrointestinal tract because you lose the acid there. The other problem with the gastric bypass surgery is the possible dumping effect. The dumping effect refers to a phenomena when the drug passes really quickly to the intestine. Usually, the drug is digested in the stomach first, and the stomach will release a small portion of the food to the intestine at a time. In the dumping effect, the food will really move quickly to the intestine, and this results in side effects such as nausea, diarrhea, and fainting. The other surgical techniques include adjustable gastric banding, gastric sleeve surgery, uh, biliopancreatic diversion with duodenal switch, and finally the intragastric balloon.